Welcome to the Auburn Career Center Public Safety Program's EMS program Preceptor training. This has everything to do with your facility and taking care of our EMS students at all levels, EMTs, paramedics, and high school EMTs. Some of the information presented here is specific to certain levels of EMS providers, and I'll try and make that aware as we go through the slideshow. This show is going to be approximately an hour in length. If you have questions, Sean Davis's contact information is within the slideshow, and I encourage you to reach out at any time with any questions. There's no simple questions, there's no complex questions. We want to make sure that our students are getting the best clinical education they can get, and that's the whole reason for this program. So here we go. So clinicals have been a long-standing part of many different types of medical training for another number of years. EMTs, paramedics, nurses, doctors, respiratory therapists, they all have some sort of a clinical hands-on application of skills that they have to complete. It has to be tracked and recorded, and it has to be a part of their initial education. EMS is no different. It's just complex on how it's done. It's generally a mix of in the field and in a hospital. Reason being is the hospital is a significantly more controlled setting than in the field, where there's more people around and there's more opportunity for the students to be guided in their initial education. So start off with the definition of a preceptor, which is something that has grown over the last couple of years. It's very simple. It's you. It's anybody. Anybody who watches this video and wants to take on the responsibility of helping to teach new students. Everybody who has contact with an EMS student in a clinical at one point in time should have been doing some sort of a clinical on their own in their initial education, whether it's a nurse, a respiratory therapist, a doctor, another EMT, or paramedic. And I want you to remember how nervous you were when you were there for the first time, your first clinical rotation, your first couple rotations, your first encounter with a live patient. And I want you to put yourself in the shoes of these students. Now, we've done plenty of simulation before they get to the actual clinical time, but they're still nervous because it's not a plastic latex mannequin anymore. This is a live patient. And if you don't want to be a preceptor, if you don't want to be responsible for a student, make sure your boss knows that, so that they're not assigning a student to you. It's important that they get a good quality education, and they get good preceptors that want to have students. But I encourage you to remember that you yourself had to be a student doing clinicals at one point in time, and if nobody ever wanted to have students in clinicals, then how would you have ever been trained? So somebody took you under their wing at one point in time and taught you, and that's what we're doing. We're bringing in the next generation of healthcare providers. So when students come to you for clinicals, they're going to have a pretty fancy sheet of, hey, these are the goals and objectives that we're here to accomplish today. There are going to be examples of those sheets in the slideshow to follow, but when you ask a student, they should be able to answer very clearly what it is that they're there to do today. And everybody always gets caught up on clinicals of the skills. You know, what do you have to do today? Well, I need to start 5 IVs, and I need to do this, or I need to get 2 intubations. Yeah, the skills are important, but it's the application of the skills that we really want them to know. Why are we starting these IVs? Why are we intubating these patients? Why are we giving these drugs? And that's the key here is students see, well, they've got to start this many IVs, and they've got to intubate this many patients, and they've got to get this many meds, and they just see it as a raw number of I've got to complete this thing so many times. But the big picture picture behind it is they need to see that many IVs, they need to see that many intubations, they need to give that many drugs, they need to do that many things to understand the application or the theory behind it. It's not just a arbitrary number that is come up by a bunch of people in a back room. This is this is what it takes for them to understand fully why we're starting IVs and doing these different skills. So our goals, what I was just saying, is those numbers that the students get caught up on a lot, but they need to see 50 patients, 50 adult patients, 30 geriatric patients, and again it has some breakdowns. 6 of those 30 have to be trauma, 12 have to be medical, and then you can go any combination of medical and trauma after that, okay? Pediatrics, of which they have to divide the ages of those 30. At least 2 must be newborns, 2 must be infants, 2 must be toddlers, 2 must be preschoolers, so on and so forth. And they have the same 6 and 12 requirement for trauma and medical. And then out of those 110 patients, they have to see 140 complaints, as you can see here on this list. And it's quite in-depth, a lot of different complaints that they have to see. And you say, wait a minute, you said 110 patients, how can we have 140 complaints? And it's quite simple. It's very common for a cardiac chest pain patient to have chest pain and respiratory distress. So they get to count those 2 complaints for that one patient. Abdominal pain and respiratory distress, altered mental status, and when they wake up they say, oh, I've got chest pain. Any of those number of things. Shock patients can fall into many of these different things. So quite a big list here. I'm not going to read the whole entire thing, but the key here is when they're in the emergency room, they're looking to get these 140 complaints done so that when they do get into the field, they don't have to worry about complaints. It's literally just the 30 patients they see in their internship, through their field learning, and then the 20 patients they see through their internship. I'm going to explain that a little bit further here in a second, but their ER, they're going to work hard in their 140 total hours of ER time to see 140 complaints. It's essentially they see 1 complaint per hour. And we know that if a patient hits 2, 3, maybe even 4 different complaints, they're ahead of the curve on that. The students are primarily, this goal set you see here is for paramedic only. EMTs only have to see 10 patients, of which 5 are adults, 2 are pediatrics, and 3 are geriatrics. And it doesn't matter which complaint they have. So the EMTs have it pretty easy. This big list here is just for the paramedics. So when the paramedics have their patients, they also have to see a minimum of 30 patients in the back of an ambulance while doing field experience, and then 20 of them as field internship. Now we're going to talk about what field internship is later in depth because it's a pretty big deal, but during field learning, they're allowed to be coached, helped, and guided by a preceptor. During internship, they are essentially in charge. They've learned every single thing there is for a paramedic to know, and they should be in charge of that call, and the preceptor should only be stepping in if they're about to perform a harmful procedure or do something wrong. Otherwise, the preceptor should just be helping. This is for pre-hospital only, field internship. They will never have a student in the field internship at the ER at all, ever. And then here's just the skills, the list of skills that they're going to need to see or do. 20 IV drugs, 2 sub-Q drugs, 10 IM drugs, 20 nebulizer treatments, 100 IV or venipunctures of any type, blood draw, simple blood draw, 10 live intubations, 4 births of a newborn. Unfortunately, twins only count as 1 birth. I didn't make those rules, but I think it's really weird. And then they have to interpret 30 EKGs, which is really not a problem. They have 140 patients. Most of the time, those 140 patients will have some sort of an EKG done. As long as they're putting an interpretation with every 3rd patient, they're pretty good. So here's the one that a lot of places ask me. So here's the breakdown. How many hours are students going to be spending in each of your rotations? All right, so cath lab time, generally we do 4-hour shifts. They're going to do 3 4-hour shifts. Communications time, 1 6-hour shift. The emergency department, 140 hours. And I can't tell you how many 8-hour shifts. Obviously, I could do that math, but what I'm saying is most students are going to do 6 here because they have some time, 8, 12s, maybe even 16s, which is the max they're allowed to do in a single day. ICU is 16 hours, and it's just 2 8-hour shifts. Field learning time is 180 hours. Again, how they're going to break that down, that's up to them. Generally, they don't do less than 6 hours, but some will do 12, and most field learning sites will only allow 12 hours a day. Field internship time, that's where they're in charge. That's at the end. They're doing 70 hours there. Respiratory therapy is 40 hours, and we break that down to 8 hours, 1 shift per month. Respiratory therapy is our favorite place for our students to go. They get to see the most amount of patients across the most diverse background and complaint and history. And the reason why we do 8 hours each month is because as they go through their 5 months of clinicals and they learn more and more things about patients and patient cares and trauma here and medical there and pediatrics there and so on and so forth, that respiratory therapy is that overview of the entire hospital, and they get to add in those little bits of things that they're learning as they go along. So it's one of our favorite places for students to go. Unfortunately, so many students get caught up and they're just there to give nebulizers and listen to lung sounds, which is just not the case. They get to see that whole hospital, and they get to see patients in all sorts of different stages of the healing and rehabilitation process. It's just a great dynamic place for them to be. So that's why we break it down, and we've really made honest efforts to tell the students that they're there for more than nebulizers and lung sounds. Anesthesiology, or OR, 22 hours, but they've got to get 10 tubes. Depending on the rotation of anesthesia students, the doctor anesthesia students, and now medics from the ER and stuff coming in, they've been having to go over that 22 hours, but that's the minimum amount of hours they're going to spend. OB, obstetrics, they've got to see those 4 live births. If they're doing 24 hours, that generally speaking, they're able to get those 4 live births. They generally do them 8-hour shifts at a time. However, they'll call the OB floor, and if they don't have anybody anywhere close to labor, a lot of times they'll only come in for 4 hours, the second back half of a shift or something like that. But they had to have signed up on the schedule in order to be able to do that. But they're doing a total of 510 hours of time. Again, just another little clarification and breakdown. Cath lab isn't done until they start cardiology, which is about the 3rd month of clinicals. Communications time is done right at the beginning. ER time is done in the first 3 months of clinicals. They do not do emergency room time and field learning time at the same time. So the ER nurses that are listening to this recording or hearing this, you are the first real contact that these medic students have with patients. They're green, and you are the foundational education for them, how to start IVs and stuff. That the IVs that they start with you are the first IVs they've ever started on a live patient. Up until then, we're just doing the IV arms in the lab room, the high fidelity mannequins in the lab room, and then their patient encounters. They're those sorts of things. You're the first, and you're giving them that baseline education. And by sequencing the program this way, we found that they have been significantly more successful, because the ER again has paramedic techs and nurses and doctors, and they have a lot of help, and they get to ask a lot of questions, and you guys really do a really good job of clarifying things for them. ICU is done at the end of medical, when they're done with both cardiology and medical, and it's generally done in 1 month. And it's for them to really just get the understanding of that complex medical patient. It is also done at the transition between the ER and the field learning time. So it's the closest we get to those extreme patients that they might have to deal with in the field before actually being in the field. ICU nurses, you guys do a great job of showing them those complex cases. Field learning time, again, this is where they're going to start running the ambulance. The preceptors can coach them, help them, work with them. It's a team effort. But that internship time that's done in the ambulance is at the end, after the students have learned everything that they can know, and they shouldn't be coached. All right, very simple. So a student gets to your rotation and you want to know what they should be doing, ask them. Each student has a paper of skills that they're signed off and able to do, meaning they've done it in simulation, in high fidelity simulation, and they've proved competence and that they are able to be doing it on a live patient. Ask them. If they don't have that paper, I encourage you to send them home. They know they should have that paper. They also will have, again, forms that say during this rotation they're to be meeting these goals and objectives. Students are going to be vocal on this. Hey, I really need this. I need to get a couple more IVs. I need to get this. I really need to see some patients having chest pain. I need to see some psych patients. They're really good about telling you, but if you question whether they're able to do it or not, they have a paper that can explain what they can and can't do. We're going to transition this to a badge here shortly where it'll be on their badge, but we haven't gotten that far yet. So I really hit this up already. Again, anybody in hospital, you're never going to have to deal with this clinical versus internship time. This is strictly a pre-hospital setting. So you preceptors that are working in the ambulance with our students, this is what we're talking about. Clinical learning versus internship. So clinical learning means that they don't know everything that a paramedic knows and they're still learning. They might need coaching. They might need you to show them better techniques or intervene. During internship, which is the last month and a half of class, they've learned everything. They've learned the entire medic book. They've been through everything. They've tested out on everything. They are literally just doing review for the entire month while they're internshipping. Internship is done at a single department. So, you know, where they can ride anywhere they want during clinical time, internship is done at a single department, and there's only one student from Auburn at that department at a time. There's only ever one student per rotation, but we go as far as to block off where, for example, student A picks Mayfield Heights, student B picks Concord, student C picks Painesville City. Those would be the only students there during that internship time. You won't see any other students rotating in from Auburn. Now, if we share that site with somebody else, of course, shared sites can still come in, but from Auburn, you're only going to see that student during that internship time. And again, that student needs to be judged on his ability to, within a month, he's going to graduate from paramedic program, he's going to take this national registry, he's going to pass it, and he's going to be a paramedic on his own. So you really need to be kind of hard on them with that. You know, make sure that they know what they're doing, that they're able to be a competent, functioning paramedic, because you're their last safety net. Because in a month, they're going to be a paramedic, and they're going to be on their own. And some of these places, some of these people don't go work at places where there are a bunch of paramedics. They might be one of 4, one of 5 on the entire department. So we need to make sure they're ready to function as a paramedic. And again, that's team leader, must be there. The only time the preceptor should come in if they are going to do something dangerous or wrong. The preceptor is still allowed to clarify protocol-related issues. Our students ride at 30-some different sites with gosh knows how many different protocols. They can't know every protocol. So they would say, hey, you know, this patient needs analgesia, and, you know, I'm going to give fentanyl. What is your protocol's dose for fentanyl? And you say, oh, okay, our protocol is 50 mics. Okay, that's not helping them. They're not knowing your specific protocol. So that doesn't count as you helping them. That's just giving protocol-specific guidance, which they're not to know every protocol that they run under. So here's some just important rules. Students must be supervised at all times. If they're going to perform any sort of invasive procedure at all, this includes DSIC, they must be supervised by a nurse. IVs, drugs, all that kind of stuff. Now, if you need some orthostatic vital signs or just a quick set of vitals done, or the student is needing to question a patient about some assessment findings, they could do that without being supervised because it's nothing invasive. There's nothing that's going to hurt anybody. But if it's something invasive or has the potential to cause harm, they need to be supervised at all times. Students must be in uniform at all times. If you do not feel that they are presentable, professional, and maybe if they smell a little bit because they haven't gotten a shower, you let us know. You send them home, and you let us know that you had to send them home for a uniform violation. They must be professional and look the part. The ERs requested a long time ago that we color code our students. So all of our EMT students are going to be wearing navy blue, and all of our paramedic students will be wearing black. They are clearly labeled on the shirt as well, where it'll say EMT student or paramedic student, but we also color coded them as well. Again, we're looking for preceptors that are willing to help students learn. If you're not willing to help the student learn, please do not take them under your wing. Please do not be a preceptor. Find somebody who wants to help them learn. And again, I encourage you to remember that at some point in time you had to be a student during clinicals, so there should be nobody that says, I don't want to be a preceptor. All right. Students cannot be used to supplement any sort of manpower or staffing levels. They are extra, always extra. And if you want to see the entire handbook, the students have access to that on their Blackboard, and they can give that to you, and I've also given it to all your managers. So just let us know what you need. I kind of covered all this. Students should be a little bit early. They should be ready to go. They should be in full uniform. You got to give them a break every once in a while. You got to let them go get some lunch every once in a while. Students will be using their cell phones. We use Platinum Planner, and they document all of their patient encounters on Platinum Planner. If you notice that they're playing games on their cell phones, please make note, call me. But if they're using their cell phone to enter data, like most of them will be, please allow them to do that. Plus, they are using their cell phone to check in with GPS when they get to the site. It gives me a timestamp that, hey, they were supposed to start their shift at 10 a.m. at Lake Health Tri-Point, and they're there at 9:58, and they check in GPS, and then they're supposed to be there till 5. They check in at 5. And fun thing, that phone does random checks without them knowing to make sure they're still at Tri-Point between 10 and 5. So they should and will use iPhone or their phones or iPads to help document their encounters. We're really trying to get away from paper, as I'm sure a lot of your sites are also doing. So if you think it's a problem or you think they're abusing their electronic device, simply reach out to me and let me know. Otherwise, they are using that electronic device for clinical documentation. If you have downtime, the students should be using that downtime to study. Shouldn't be chilling in a recliner. Shouldn't be getting into trouble. They have a lot to study. They've got a lot of homework. Again, some of them might be using the Platinum EMS testing, which is the other side of our new software, to practice tests. And if they're doing that, I would encourage it. Again, if you think they're abusing electronic devices, simply let me know. But they've got to answer about 200, 300 questions a month on their own, and then they're going to have anywhere from 100 to 150 questions a week due for assignment. So they've got a lot of questions to answer, and they can do those on their phone or their iPad or their tablet as well. There are very few places for preceptors to sign now, and we've really streamlined that process. It's actually one signature and some initials that you've read that. So here's some copies of the paperwork. Here's where your first signature is going to be. As you can see here, this is the attendance sheet. Depending on how this GPS thing works, this might be something we're going to be getting rid of because we have this GPS, but this is our first year using the GPS, so we're going to get used to it. But it's a simple date, where the site is at, time in, time out, total time, and as you can see on the far right side, the preceptor initials that they're not making this up. Yeah, they were there at 10, they did leave at 5, they are at the emergency room at Tri-Point, the date is the 5th, so on and so forth. Just a verification of they're not lying. I just picked a standard form here. Class Lab is our shortest, most simplest form that I could fit onto the page without distorting it too much and still making it legible for the presentation. But each one of the rotations they go on has a form that's just like this, where they'll put their name, date, time in, time out, the hospital, that kind of stuff, and then they'll have a number of objectives. Cath Lab only has 5 objectives, as you can see here. But emergency room and field internship have the most, with right around 15 objectives. So this whole front page is pretty much just a list of objectives. But it's simple. The students filling out, what did they do today? Did they understand and get to learn about the anatomy and physiology of coronary vasculature? Yeah, they did. No, they didn't, or it wasn't applicable because we didn't see any patients coming in for catheterizations. Maybe they were ablations that day or something like that. So they still got to do stuff. They just didn't get to do cath lab coronary artery stuff. They got to do ablation or something like that. But they circle yes, no, or NA, and that is the student circling what they felt they learned that day. And that's the top half of the form. And then here's the bottom half of the form, that same front page. And this is where the preceptor is going to print their name, sign their name, date and time. And the reason I ask for a print is sometimes these signatures, I have no idea who they are. And I need to get a feel of who this is. If I have to ever go back and track stuff down, it's easier to track down, John Doe versus a squiggly mark that might be Jane, John, Jimmy, who knows. And you're to rate them on a scale of 1 to 5. If you give them anything less than a 3, I'm going to be calling you. And that's another reason why I need a print, so that I can see how we can improve this student. A 1 and 2, that's significant improvement that needs to be shown. 3, 4, and 5, that's self-growth. They can improve themselves at 3, 4, and 5. But 1 and 2, one of the teachers needs to get involved and help them to grow up to that 3, 4, 5. By the end of class, we expect them to be getting solid 4s and 5s, nothing less. But anything less than a 3, I'm going to call you. And by gosh, am I not going to be defensive of the student? I just need to know how we can help them improve. That's going to be my phone call. I'm not going to be, what do you mean they got a 2? I'm going to be, hey, they got a 2, and what do I need to do to get them up higher? That's going to be the honest thing there, because we want our students to be great functioning EMS providers that are 5s all the time with every patient and every interaction of healthcare staff and all that kind of stuff. Here's the back of the form. Now, I know there's a lot of stuff on here, and unfortunately this is how the national curriculum / national accrediting body wanted us to grade skills performed by students, and I did not choose this, but essentially the student will write in there the skill, and I totally encourage this. On line 1, if they started 6 18-gauge IVs, just write in there 6 18-gauge IVs, and then the student must grade themselves on a scale of 0, 1, or 2. 0, they were unsuccessful. 1, they were marginal, meaning they have to improve to be a better IV starter, and 2, they were successful, competent with no prompting. So if they did 6 successful 18-gauge IVs and they all were 2s, then you can put them together. But if they did 3 successful and 3 unsuccessful, you'd put 3 18-gauge IVs, all 2s, 3 18-gauge IVs, 0s, because they were unsuccessful. But that doesn't mean they got 0s in everything. Maybe they were still good with some of this other 6 points that we're supposed to grade them on. Students will do the majority of filling this out. Preceptors, you simply have to go in there and put your grade, your choice grade on that patient. I don't care if you write a 2 in the first box and draw a line across. I was told that they had to have this grading scale. They didn't say anything about how it has to be filled out. So as long as I have some semblance of you're giving them a 0, 1, or 2 some way, somehow, I'm going to be happy with that documentation. As you can tell, I'm not super happy about this, but it is what they asked for. And the bottom of that form, the preceptor has a chance to write handwritten comments. I encourage this, please. This is how we get our students to grow, and if you don't write handwritten comments, I cannot help my students grow. And I use these comments to hand out awards and growth things for the students. So these comments are integral to the students' growth and end product. So, and there's simple initials at the bottom to prove that you at least looked at this page and that it was you in fact who graded them. Here's what an assessment looks like. It's 2 pages. Preceptor initials at the bottom. They do their assessment online. All right, they document it online. This is a notepad, essentially, nowadays. I do not care if they have chicken scratch over the entire thing, just to remind them, so that when they are at home after their ER shift or field internship shift or whatever it is, that's when they do the full documentation. This can be full of chicken scratch. That's all I need, chicken scratch here. Something to remind them, notes to give them remembrance for when they're doing their full-on electronic documentation. I'm hoping to get away from this form completely and go completely electronic here shortly, but we're not there yet. I already kind of went over that. So this is a very important slide. Student issues. If a student's injured, okay, exposed to a communicable disease, exposed to some sort of hazard, gets stuck by a dirty needle, and note I say dirty needle. We've had students get stuck by clean needles, and these people call me freaking out. If it was a clean needle, it hadn't been used for anything, this is a non-issue, unless of course the student is significantly injured from said needle. Okay, then you need to call me. But if it's a simple needle stick, the tip of the finger with a clean needle that's not touched a patient or anything like that, I don't need to know about that. Unless you feel that it was because they were goofing around, then I'd like to know about it. But dirty needle sticks, traumatic injuries to student fell, student slipped on ice, something happened to the student. Bottom line is, wherever they're at, if they hurt themselves, treat them. They become a patient. The students have their own health insurance. The students are responsible for their own care. But and obviously you follow consent laws. If they're consenting adults, which they are, and they say I don't need any help, fill out whatever paperwork's required for your place, sign off, AMA form or something like that, and let them go on their way. They're an adult, but if they're unconscious, implied consent says you're going to treat them to the best of your abilities until they can tell you that they do not want that treatment. All right, start treating the patient / student right away, and then as soon as you can, notify me. And there's my name, there's my contact information, there's my email, that's my cell phone. 2 in the morning, if my student's at your ER 2 in the morning and they get hurt, call me. Plain and simple. Leave me a voicemail. If I didn't wake up on the initial call, that constant beeping that my phone does when you leave me a voicemail will eventually jar me awake, and I will take care of it. But I need to know, and I need to know right away, and there's no hesitation in calling me if something happens. Write that number down, put it in your cell phone, post it on your board. I don't care who has this number. It needs to be posted. If Auburn Career Center student has an issue, behavioral or physical, or one of these issues here, they get hurt, that phone number needs to be called ASAP, and we need to get taken care of right away. Okay, and again, if they're sent home or you feel that they need some sort of discipline, call that number, let me know as soon as you can. All right, so that's really about it. It's a quick, easy thing. When there's no questions, and this is recording, it's a little bit quicker, but that's my contact information. There's my office phone, 440-358-8026. That also goes, when you leave a voicemail there, it goes straight to my phone, so I can get that voicemail pretty quick. There's my email. You need anything at all, email me, call my phone. There's my cell phone again. Bottom line is, we can't teach our EMS students without preceptors and clinical sites and all of the stuff that you guys do. And we're appreciative of everything you do for our students, and you're the reason why we have such a high good success rate with students, and why our students become such good working professionals. And I just want a simple thing. When you complain about interacting with certain paramedics in the field, you think to yourself, man, where did they go to school, right? And this is where you have that direct ability to influence that future generation, so that you don't sit there and think to yourself, man, where did they go to school, or how did they become a paramedic? Because we're going to stop that. We live by a simple rule at Auburn Career Center. Our class saying is we're not here to get you to pass a test. We're here from when you're the only thing between the patient and the grave. And what that means is severalfold. We're not just teaching students to a test. We want them to be competent, confident EMS providers. And 2, we all have another simple rule, and it's funny to hear how the lawyers wrote this rule into our handbook, but it's very simple. None of our instructors are going to graduate a student if we do not feel comfortable with said student taking care of our mom and dad. Every patient that we run into is somebody's mom and dad, and that's how we're having our students make sure they treat every single patient they come into. And if you don't see that behavior, if you see our students that they just don't seem to care, or they need to have a professional attitude adjustment, again, I want you to call me. I want you to let me know so that I can get in there and adjust that behavior now before it gets set in stone. This is the time when we can mold a student to something just amazing, and we have the ability to set the trend of the future of healthcare providers, EMS providers in our area, and that's what we're living up to, I hope. So if you ever have any information that you need, any questions, anything regarding our program, do not hesitate to email, call me at one of these numbers. I'm always happy to hear about students, and I'm always happy to receive feedback, and I'm always happy to hear suggestions. So thank you for your time today. I greatly appreciate it, and I will see you around dealing with our students.